Hi everyone, welcome back, and thank you for the great support you gave for the initial collaboration myself and Dr. Thala did. And we plan to continue because it's exciting for us as well, and we are enjoying this process. And your feedback keeps us going as well. So, how was your holiday, Thala? Welcome back.
It was fantastic. Thank you so much.
That's,
A little bit jet lagged on the way back, but it was so great.
and
Thank you.
it was nice to see the difficulty you had in replying to the comments and things during that period. So,
Yeah,
internet
I
is a
know.
blessing, and we take things for granted. Moving on to today's topic, we discussed labor room approach to extreme premature babies, and one of the most fascinating parts of neonatology is ventilation. Obviously, in the early 70s, when mechanical ventilation in neonatal units started progressing, there were only one or two modes, and then with Gregory studies and the impetus on CPAP, and of course, recent studies by Colin Morley and team, and all other researchers, we have progressed a lot in non-invasive support, and the ventilators have become more and more sophisticated. We have more and more focus on synchronization, patient control, and volume guarantee, and so on. And of course, even high frequency has become very sophisticated. So, shall we discuss a little bit on ventilation today and how we approach the choice of modes? And
I would love that. I would love that.
thank you.
One of the things that we were both discussing before we started recording is that, and we're both in the same camp as this, is that none of us really know exactly what the best type of ventilator to use at any moment is. With all these studies that are being done, nothing's been categorically proven that the high frequency ventilators reduce BPD or whatever else. So this is really more about what we kind of do. I think everybody agrees that whatever ventilator you use, it should be the one that provides the absolute least support that you can and still ventilate and oxygenate the baby. So that's always our goal. Whichever ventilator that you're using, you use the least pressures, the least volumes, whatever it is, so that you can still get the baby to breathe, but you are not damaging the lungs further. I just thought
Exactly.
that was an important point to make from the start.
And supporting the physiology, I'll elaborate a little bit on what you said. What we are doing is basically get the baby out of the woods. We are doing just enough to keep the baby safe and supported, meet the requirements that are essential, not overdo it, not underdo it. So it's a fine balance, and not overdoing is very important because many younger doctors, many budding neonatologists may actually get over enthusiastic and overdo things. So you have to hold back a bit, think about what exactly are you doing. Your aim is to support the physiology and help the baby come out of the transitional physiology or the difficulties. PPHN is a great example for this, because if you look at the pathophysiology of PPHN, you have different scenarios. You can't approach all of them the same way. And the same applies to almost any aspect of ventilation. So before we start, do you want to just give our audience who may not be totally conversant with the different modes, do you want to just give us an overview of what options we have, and then we will dive deeper into where we use what?
Yeah, so we have the high frequency mode. So in our unit, actually the main one that I work in, we do have the jet available as well as the oscillator. And the jet, these are basically perform a different way of gas exchange. So it's not the kind of pressure in, pressure out, pressure in. It more like vibrates in and vibrates air out again. The oscillator is kind of separating ventilation and oxygenation and really has its whole different way of gas exchange. The jet is kind of a combination between high frequency as well as conventional vent, and it still to some extent uses the difference in pressures to kind of vibrate that air in and out. So those are kind of the high frequency ventilators. And then we have like the conventional ventilator. There are loads of different modes that we can use, but it basically breaks down to two main modes. And that is whether we've decided to deliver a pressure or whether we've decided to deliver a volume. So pressure guarantee really and volume guarantee. So either way, all you're trying to do is make sure that the lungs are opening up enough to give the tidal volume that the baby needs. So we're still just trying to breathe for the baby. And basically, there's just a lot of research done on which is the best way to breathe for the baby to produce less damage in the future. So we know that the main thing that causes damage to babies' lungs and causes BPD in the future, which is where you get the chronic lung disease, and we still count it as an oxygen requirement at 36 weeks. But the main thing we worry about is volume trauma. So if the lungs are overexpanded with every single breath that you're giving, that's really damaging to the lungs. People have found out that that's not necessarily as that high pressures isn't necessarily as damaging. If a baby needs high pressures to open up the lungs a minimum amount, then that isn't as damaging as giving a way too high volume. So I know that a lot of people have worked more towards, giving a volume. So basically into the machine, you type in, I want this machine to give this amount of pressure until the baby's lungs are a certain volume. And normally we go somewhere between 4 to 6 mLs per kilo. If we're unable to ventilate with that, sometimes we go up a bit. So the lungs will literally, and then you set a PEEP as well, the ventilator will deliver a pressure until the lungs are being measured to have that volume inside the lungs. Obviously, you don't want the pressures to be really, really high. So when you type in that volume mode, you do type in a maximal pressure. So you'll put in like a PIP of 30 or 35 to make sure that the ventilator isn't using massive pressures to get those volumes. So that's kind of the volume guarantee. And then in a way, there's kind of an auto wean with the volume guarantee, because as the lungs get better, hopefully, then you can see that the pressures that the ventilator are delivering to reach that volume are much lower. So the issue with volume guarantee, and I don't know if you want to talk about that now, is it's not, the ventilators are not absolutely great at measuring volumes for babies.
That's
As
true,
you all
yeah.
know, when we intubate babies.
Yeah, I was about to say that, you simplified it very well. And obviously, the main thing is about, there is no doubt, high frequency has a role in certain group. We'll discuss that. But in terms of conventional ventilation, there is absolutely no doubt that we need synchronization. So there is no doubt that we need synchronized modes of ventilation. And that is the key now. Nobody goes for CMV or IMV anymore.
And just to say this, synchronization is when it's going along with the baby's breath. So if a baby's about to take a breath, then the machine will recognize that the baby's taking a breath and give a pressure on top of that. That's synchronization. So for example, if a baby is breathing 30 times a minute, it's not going to be every 2 seconds. But if the SIMV is set at a rate of 30, then even if the baby takes a breath now and then takes a breath in 3 seconds and then 1 second, with every one of those breaths, the machine will give it the PIP. It's not like the baby is breathing and then every single 2 seconds, the machine decides to give a PIP. So even though it's not completely exact, it's very good because it means that the machine isn't fighting against the baby and they're working together. So synchronization is a fantastic aspect of a ventilator.
It has enabled us to come out of using routine sedation. So it's a very important concept that we don't routinely sedate the babies on ventilator. Previously, we used to think baby will feel pain, baby will feel discomfort, but then we were not thinking about the long-term effects of these medications. So these are all acting through neurotransmitters in the brain, in the developing brain. We are talking of steroids and the long-term effect. Similarly, these medicines also are not absolutely safe because studies like the neopain have come out to show that it's not absolutely safe. And actually, if you start using stronger sedatives like midazolam, you run into so much trouble with fluid balance and so on as well. So the synchronization is a must because it enables us to avoid unnecessary use of sedatives. Of course, in the sickest babies, we go for sedation for a brief duration, and post-operative babies we need, or PPHN, for example. But apart from that, most of the time, we don't need to routinely use. Of course, you use pre-medication for intubation, which is a painful procedure, which again is debatable when it comes to insure. So the point I was trying to make is synchronization is the most important advance. Volume guarantee has been shown in research, of course, to show a reduced BPD. Yeah. But remember that if you are sensible enough, if you're using the other synchronized modes like SIMV or SIPPV or PSV as we call it, PTV. I mean, any mode assist control, different names for the same modes. But ultimately, if you know what you're doing, as long as you don't overdo the ventilation, the effect will be similar. And all the more reason for that is we are giving only short-term ventilation these days. I mean, we try to extubate the babies within a few hours. So if you are not overdoing the ventilation, especially watching the complaints after the surfactant and weaning the pressures, it would work equally well. The reason volume guarantee shows the benefit is because in most units, the junior, most people are the ones on the ground. They don't really understand the exact mechanics, and they allow the baby to get to excessive volumes after the surfactant is given. If you're keeping the same pressure, the complaints changes after the surfactant and there is overdistension, and that's where you damage the lungs. So if a competent person is watching, a senior or experienced person is watching, and they know exactly what's happening, the effect will be similar. But in a larger group and in a bigger unit, for example, this is the only way it will work. The junior people will be the ones on the ground. And so volume guarantee makes it easier by regulating it. I mean, the pressure adjustment is done by the ventilator, because the volume delivered will obviously be at a lower pressure when the lung compliance is improving. Do you want to comment on what compliance is in simple terms?
Yes, yeah. So compliance literally means the amount of pressure that's needed to change a volume. So I always give the example of blowing up a balloon. Right at the beginning, when you start blowing up a balloon, it's really low compliance. The balloon is really, really like thick and stiff. So you have to use a lot of pressure to get a little bit of volume. And then afterwards, as the balloon starts enlarging, the compliance is a lot lower. So you need less pressure to produce that volume. And the lungs are kind of similar like a balloon. Right at the bottom, when they're completely collapsed, they're really stiff, so their compliance is low. There's a golden period in that lungs where they have good compliance. And then when they're really hyperexpanded, obviously to get them to open up even more, then the compliance goes down again. So that's kind of compliance within the same lung. What we're talking about here is how the compliance of the whole lung changes. So first of all, when babies are born, they've got fluid, they can be really immature. If they're lacking surfactant, then the lungs are really stiff. By definition, we are giving surfactant to make the lungs less stiff, so to improve the compliance. So the point that Dr. Stritter is making is that if you are on a pressure guarantee mode and you give the surfactant, then suddenly the compliance is going to improve by so much. So if at the beginning, right before, say we were on pressures of like 23/6 on your ventilator, and we haven't given surfactant yet. So initially with 23/6, that was delivering a tidal volume of 4 mLs per kilo. After you give the surfactant, the compliance improves by a lot. Maybe suddenly your volumes are going up to 10 or 11 mLs per kilo because the compliance has improved so much. So delivering the same pressure will open up the volume so much more. So the point that we're making here is, if as you're giving the surfactant or periods where you expect the compliance to change, if instead of delivering a set pressure, you're delivering a set volume, then the machine will just give a lower and lower pressure. So obviously, if you're sitting by the machine all the time and actually decreasing the pressure as you're seeing the volume go up, then yes, that would be better for the lungs. But the argument that you could make is that we're very rarely all sitting by that. So we can't set up a system for the hospital where like the provider is just sitting by the machine typing stuff in all the time.
I mean, all of us have done that as we train, but of course,
Yes,
it's difficult
absolutely.
in a very busy unit. And
yeah.
Even if you have the best intentions, I mean, if you are the specialist or registrar on the ground and there are 3 babies who are sick at the same time, you cannot really spend. So the volume guarantee takes over, the same with the closed oxygen system as well. I mean, it makes it easier for us to do what we do, but we shouldn't be dogmatic about it. One point I would like to make here is overdistention. Why does it harm the baby? I mean, there are different things, and one is the carbon dioxide washout, which is very important for the brain development as well. And the chronic lung disease risk is increased if you're washing out, again, due to the overdistension. The vasoconstriction, which is produced by a low carbon dioxide, the hypocapnia, is going to impact the premature baby's brain vasculature in the circulation. So it increases the risk of PVL. Even if it's not visible PVL, you may get subacute or subclinical injury to the brain, so it may affect their future development. You do come across situations like lack of antenatal steroids. Despite the best efforts, there are some mothers who come suddenly and deliver even though they are premature. maternal infection, corium neonitis. So these are situations you expect that the lung is going to be really stiff. And PPROM, for example, I mean, the baby comes out after a few weeks of prolonged rupture. So in these situations, you should have a lower threshold to give surfactant early, because even giving the normal pressure that you would use in these very stiff lungs is going to increase the risk of, it's like flogging a dying horse. So if you're using a higher pressure, you're going to break into the lung tissues. That's called the pulmonary interstitial emphysema. Thankfully, we don't see too many of those. In the days before the antenatal steroids were prominent, we used to see a lot of PAE. But PAE makes it very difficult for the lungs to ventilate in the acute stage. But also in the later stages, the risk of BPD is much higher in these babies with PAE. So these are the babies who typically go for the DART regime, steroids to extubate and so on. So what are your thoughts on air leaks and the timing of surfactant?
Well, obviously for me, if a baby is intubated, if a preemie baby is intubated, we're giving surfactant. So anywhere between 30 to 32 weeks, if we're intubating a baby, we're pretty much giving surfactant. If a baby is, on NIPPV or a non-invasive pressure mode or on CPAP, then in our hospital, we're doing LISA, less invasive surfactant administration. So I would say that, anything, bad chest x-ray, increased work of breathing, FiO2, 30 to 35%, just kind of the overall gestalt, which way the baby is going in. Is the baby getting worse or is the baby getting better? Then we will administer surfactant.
So what kind of pressures on non-invasive do you accept before you give surfactant?
Well, honestly, if it is a preemie baby, for example, if it's a 25-weeker who is on CPAP, then we're not going to push that baby too much. So if the baby will go to 6, maybe 7, but at that point, that baby is telling us that they would probably benefit from surfactant.
Exactly.
If it is a 33, 34-weeker that, obviously babies start making their own surfactant in 2 to 3 days, then we'll do like a little bit more, we'll be slightly less aggressive with that. That, maybe we would, accept slightly higher FiO2, 35-ish. Really, for me, it's not just about the FiO2. It's about, obviously, the CO2. It's about what the X-ray looks like. If the X-ray is like really, really hazy, then this baby's only going in one.
You were mentioning about micropreemies and how we are handling them different. So do you want to share your thoughts? I mean, you started by saying the jet ventilator is used in micropreemies. We don't have jet ventilators. We just have the high frequency and the conventional, but of course we manage as best as we can. I know the Iowa team uses a jet ventilator for the extreme preterms as a routine. You're following the similar. So do you want to give us an idea of how you approach it?
Yeah, so I mean, as we talked about in the last kind of discussion, really our goal is not to intubate babies like in the delivery room. And so really what I talked about is kind of 24, I would say that a lot of those babies are intubated. 25 weeks, we're really hoping to get those babies out of the delivery room on CPAP or non-invasive ventilation. But really 22, 23 weekers, we're pretty much intubating and giving them surfactant. And generally we're putting those babies on the jet. I think we've all begun to realize as we're resuscitating younger and younger babies that those 22 weekers are just kind of a different ball game altogether. And I feel like we are all beginning to realize that maybe we should be treating those babies differently. Maybe they aren't the babies that we're trying to, stabilize and extubate as quickly as possible. We've all kind of realized that these babies need a lot more support. So really our 22 and 23 weekers are staying on the vent for some time. And as we've all kind of come to feel, the high frequency ventilators, the hope is that they're gentler on the lungs and they're less likely to damage the lungs and therefore contribute to chronic lung disease or BPD. So yes, in our hospital, we generally put these babies on the jet. I really do want to emphasize, though, that study over study has shown that there isn't one single type of ventilator that is the best. You brought up Iowa. Their numbers are exceptional with the 22 and 23 weekers. So yes, we like to think that we are trying to be more like Iowa. But really, if you look at the studies, nothing has conclusively shown that if babies are on the jet, they're going to get less PPD. So yes, after babies are born, we put them on the jet. We're putting them on the lowest kind of values that we can, rates of kind of like 360, pressures if we can. And the tiny babies will go all the way down to 7, like of PEEP and a PIP of 20, 21, which is really low for jet. Obviously, very soon, those babies end up going higher. So we'll take up the PEEPs to 8, 9, 10, pressures up to kind of like the mid-20s. But really our goal is, as we keep saying, to use the lowest amount of ventilator support needed to give the babies what they need still.
So do you use the 2-size ET tube as well, or you are managing with 2.5 in the tiny baby?
We actually are using a 2.0 ET tube. Obviously, even in the tiniest babies, we'll try to put the 2.5 in. The 2.0 has to be kind of, the respiratory therapists have to get kind of really smart with how they can set that up with the jet, but they've somehow figured out some bypass to be able to put those babies on the jet and to be able to suction them. Those have kind of been our problems in the past with the 2.0 tubes.
Kinking as well. Baby tends to kink quite easily, isn't it? So
even if a baby does have a 2.0 tube, we will try to upsize that as soon as possible. So like within a few days after birth, we try not to do anything really critical within those first 3 kind of no stimulation days of life. Those peak days of getting an IVH, we'll try not to change anything. But then after that, really within a few days, we'll try to upsize it to a 2.5. And most of the time, these babies, even if you just were able to get a 2.0 and couldn't get a 2.5 in the delivery room, most of those babies can be upsized. We're finding now that after about 2 to 3 weeks, they kind of plateau out on the jet, a lot of these babies, and that's when kind of the peak inflammation comes in. The happy honeymoon period is over in the first few days of life. So a lot of these babies at kind of 2, 3, 4 weeks of life, we're then switching them over to the vent, to the conventional vent. Like the gas exchange stops working as well. Sometimes
do you wait in these babies for the steroid, the postnatal steroid, do you delay it more than what you would for the bigger babies?
You know what? We're still all in the discussion of doing that. You know, a lot of these studies are coming out now that if we're going to give the steroids, we might as well get on lower vent support and give it earlier. So, you know, some people are starting at kind of a couple of weeks of life. We've also found that a lot of these babies do have a general mineralocorticoid deficiency. So we might be starting them on a hydrocortisone anyway. A lot of these babies do have the duct. So we're also kind of beginning to realize that even the PDA, we should probably be more aggressive with getting rid of this PDA than we were in kind of the 27, 28 weekers that were like, it's going to close eventually. We'll just get them through this. You know, these younger babies, they've got such a high risk of bad BPD that I think we're all beginning to realize we have to be really aggressive about everything, about decreasing the amount of support we're giving them on the vent, about getting rid of the PDA, giving the steroids early so that we can get them down to a less aggressive mode of support and like lower pressures. So I think really what we're all beginning to realize is those 22 weeks and early 23 weeks are just a different ball game, you know, with the jet. If we do have to intubate a 26, 27 weeker, we won't necessarily put them on the jet. If the babies are tiny, if they're very IUGR, they're 500 grams or whatever, we will. But if we kind of feel like they just need to get over that 2-3 days and then we can extubate them, we'll put those babies on a conventional vent and we'll try with a volume guarantee. One of the things that I wanted to say about the volume guarantee is on paper, it's perfect. You ask the machine to deliver a volume. The machine gives a pressure. It kind of weans by itself as it gives lower pressures. In reality, as everybody knows, we use uncuffed ET tubes. We like having a leak around the ET tube because we hope that it's less likely to damage the trachea and the vocal cords and everything. So with a little bit of leak around the endotracheal tube, it's really hard for the machine to gauge exactly how much volume the baby is actually getting. So if you have a massive leak on your ventilator, then volume guarantee is not going to work. And sometimes that leak is kind of positional. If you turn the baby on one side, they have a leak. If you turn the baby on the other side, they don't have a leak, which, you know, can sometimes work. But if babies do have a big leak, then generally volume guarantee isn't going to work. And, you know, I don't know how you feel about upsizing tubes. Whenever we upsize a tube, I'm always kind of like, well, if we're taking the tube out, we might as well see how they do without the tube at all. But sometimes there are babies like a 600, 700 grammer that has a 2.5 in that has a huge leak. That doesn't feel great. Generally, I try not to put a 3.0 tube in until a baby is a kilo, because just mentally you're kind of like, this is going to damage a 600-700 grammer. But if you can't ventilate and oxygenate adequately, sometimes we do have to upsize those tubes earlier. Is that kind of how you feel?
Yeah, I mean, intubation is to be taken seriously, and any change of the tube shouldn't be taken lightly in these babies, except for, you mentioned earlier about the 2.0 size. So obviously, leak compensation is a component in some of the newer ventilators like the Traeger. To some extent, they're quite efficient, but you cannot rely on them fully. And I would refer to Professor Bankalari's lecture on this ventilator modes. And you shouldn't be bogged down by thinking that only volume guarantee works. So we have to come out of that. And if you see that the delta P, I mean, the pressure difference between the PIP and the PEEP is very low and the baby is actually working hard, either you have to adjust your volumes, you go to very high volumes, which you may not be comfortable with, or you switch to what you think is reasonable pressure on SIMV or SIPPV, and we call it PTV these days. So you just have to titrate the older forms, but the synchronized modes. And as long as you're on a synchronized mode, as long as you're monitoring the pressure, monitoring the baby's gases and things like that, you should be fine. And obviously, when this temporary blip switches on, you can move back to volume guarantee. So I would say 90% of the time we can manage with volume guarantee, but the 10% of the time that volume guarantee isn't working, you should be able to recognize it and say, okay, volume guarantee isn't working. It's not the only mode. I know I can use other modes as well. And it doesn't need to be high frequency. It can be one of the standard synchronized modes, and you can always keep an eye out for that. So before we conclude, I'll just make a couple of points about what you said. One is the early extubation of the extreme premature babies is a no-no, because the atelectotrauma, the circulatory changes, the higher risk of IVH, everything becomes so difficult. And I totally agree with Professor Klein from Iowa, who mentions about not extubating them like as long as possible. But I wouldn't necessarily keep them till 30, 31 weeks, as he says.
No.
But normally 27, 28 weeks is a reasonable time. First 3 to 4 weeks when they are most unstable. Again, the PDA, you have to be different in your approach. And remember that a 22 or 23 weeker might sometimes behave like a standard 24 weeker. And for the same way, we don't understand exactly a 24 weeker might behave like a 22 weeker. So it's up to your clinical experience and judgment to realize which baby is behaving that way. Don't be adventurous. If you feel the baby will not tolerate an extubation in a 24 weeker, don't rush to do it. It may be a baby who is actually behaving a little more immature. We have all come across such babies, even a 33 weeker who behaves like a 25 weeker or 26 weeker.
Absolutely.
So we cannot
the dates are wrong. I mean, sometimes the dates are wrong as well, right? Like, I mean, we're saying 22 and 5 as if like we know exactly the date that a baby was, conceived. So yeah, absolutely. Sometimes the dates are wrong. And then I just want to also, reiterate that we put babies on whichever breathing support it is, and you're giving them, like I keep saying over and over again, the least possible support that will still allow them to oxygenate and ventilate. And, a lot of the machines now are also just so high tech. So yes, they do kind of account for the leak and everything, but also you can get so much information by looking at all the graphs and the charts and the numbers on the machine itself. And I would love to do a lecture about that at some point, but you're not just looking at that, you're looking at the baby. Is the baby working really hard to breathe on whatever support you're on? You're probably not giving them what they need. If the baby is still tugging away and retracting and breathing at 100 times a minute, then that's probably not enough support. You're looking at the gases as well, and you're also looking at the x-rays. So we don't want the lungs to be completely collapsed on the x-ray. We don't want them to be hyperexpanded to like 11, 12 ribs or whatever. That's probably damaging the lungs. If we have the lungs that hyperexpanded, you're pushing on the lungs, you're damaging the alveoli. So it's not just you put the baby on the vent and we watch it. You're constantly monitoring all these things to try to make sure that the baby is as comfortable as possible as well.
That's great. I mean, we covered a lot of things, very important points, and we touched on extreme premature babies. We mentioned why we shouldn't use routine sedation and identify the babies. Identify when you can extubate the baby. So where the baby deserves to stay on the ventilator longer, leave them on for a longer time, but use non-invasive modes or less invasive surfactant as far as possible in the bigger group. And don't be dogmatic about one single way. You have to be aware of the different approaches and be open-minded about it. And don't forget to see the baby, as you lastly said about the baby who's really working hard. That's what I meant by the delta P difference. When there is a very little differential, it's not ventilation, it's CPAP basically, and the baby is struggling. Exactly. You need more support. So this has been a delightful discussion, and I know we are short of time and we have to wind up now, but I'm sure we can extend this on, and I hope we have good
talk
feedback.
About this for hours.
Yes. Please comment and share your thoughts, and if you feel we are thinking of brief clinical topics like residuals in feeding, and as well as what to do with green vomits and stuff like that. So if you have any specific questions addressed as a combined session, we would certainly be delighted to hear from you. So over to you, Tala, to say goodbye for today.
Yeah, thank you so much. I love chatting with you as always. I love knowing what everybody else is doing in the world as well. So thank you. I really enjoyed it.
Good night. Bye.
Bye-bye.